Welcome to episode 232, Mind, Mood, and Menopause, Understanding Hormonal Transitions in Mental Health Care, featuring Helen Bennett, counselor and psychotherapist. Make sure to subscribe to be alerted about future episodes. By Clearly Clinical. Learn, grow, shine. Hello to our listeners. My name is Beth Irias, and I am so excited today to be joined by Helen Bennett. She is a counselor and psychotherapist and clinical supervisor joining us today from the UK for a conversation about menopause. I feel like this is one of those conversations that is so important and also one that we do not have nearly enough clinically. And I'm just grateful for her being here. Thank you so much for joining us today, Helen.
Thanks so much for having me here, Beth.
So before we dive into this very big topic, why don't you share with our listeners a bit about your background and then how this came to be one of your specializations?
Sure. So I am relatively young to be talking about menopause. I'm only in my early 40s. I am one of those people who experienced a premature ovarian insufficiency, which is an early menopause before 40. I happened to be training when the symptoms really kicked in for me. And it was one of those things that there wasn't much information about, and I couldn't really get enough support. My therapists didn't seem very capable of talking about menopause particularly, and they certainly didn't seem able to talk about menopause with somebody who was my age, which was in my 30s. I really struggled to know how to deal with it. I had a lot of the symptoms that we'll go on to talk about. And it's been an interesting journey for me, an interesting shift, an interesting change. And I decided that when I did eventually start my private practice, I wanted to focus on menopause. It was also something that when I used to work in an agency working with lots of different client presentations, that was clearly coming up a lot, whether it was with people whose family members were going through the menopause transition, whether it was clients themselves going through the menopause transition. It seemed to have much more impact on mental health than I had previously understood. So it was something that I thought, right, I need to learn more about this and I need to be able to help people.
Well, thank you for coming on to speak about it. Given how many people are experiencing this, I know I've had difficulty finding very much clinical education, and I've seen it in my clients. I've talked with them about it, but have also felt unprepared and not as well educated as I think I probably should be for something that's so significant and happens in a long enough life of anybody who has internal reproductive organs. So thank you for your work and bringing attention to this. Why don't we start just by talking about what is menopause? Like, how do we define it? What are the average age ranges? What are some of the most common symptoms? And then go off from there.
Sure. So yes, as you say, it's going to impact an awful lot of people. It's just over 50% of the population. And it's also, in terms of clinically, as to who's presenting in your room, it may be impacting everybody, whether it's family members or, other people who know about it. So yes, it's something that all clinicians need to be aware of. So the menopause transition can be talked about from the premenopause stage, which is when your reproductive organs are all working as expected. The perimenopause stage, which is when things start to fluctuate, things start to change. A lot of the symptoms start happening as the estrogen levels fluctuate more, the progesterone levels drop, testosterone eventually drops too. And there are phases within the perimenopause where estrogen is higher than progesterone, and when the estrogen fluctuates up and down, which often causes a lot of the symptoms that we'll talk about in a minute. And then you have menopause, which is one day. It's just one day, which is menopause, which is the day exactly 12 months after your last period. And then everything after that is postmenopause. So we're postmenopausal 12 months after our last period. And we often find that women, and aside female at birth, may be going through these times of perimenopause, and they may get to the magic 60 days, which is when the medics would start to realize that perhaps you're approaching the postmenopause phase or the menopause day, but then you may get another period, and then it's that clock starts again, and it has to wait another 12 months, and then you are in menopause. Obviously, if you're taking any sort of hormones, whether it's contraceptive pills, whether it's hormone therapy, maybe you have the Mirena coil, these can all mean that it's quite hard to necessarily know when your last menstrual period is. So sometimes, in fact, there's a lot of people who aren't really aware whether they're in menopause or not until they end up stopping that hormone for some reason, and then being aware. But there are things that can tell you whether you're ovulating or what's going on. But for a lot of women, they are unaware and can't really be sure, but they may be experiencing symptoms which can make it quite clear. You asked about the average age. So in the Western world, the average age is 51, and that's the age that periods have stopped for a year. So it's 51 where the day of menopause happens on average. The average age of onset of perimenopause symptoms is 47, but perimenopause can last up to 12 years. So it's actually quite normal to be experiencing perimenopause symptoms in your late 30s or early 40s. If we think that 51 is an average, there's a lot of people who are having periods into their 60s and also periods that might be stopping before 40, which is known as premature ovarian insufficiency, which is the condition that I have. And premature ovarian insufficiency affects 1 in 100 women naturally before 40. So there's also women experience premature ovarian insufficiency because of surgical menopause. Perhaps they've had their ovaries removed, a nephrectomy. They may have experienced cancer treatment, which might stop their ovaries from working fully. Most people who have premature ovarian insufficiency naturally they don't find out what has caused it, but there may be links with autoimmune diseases, there may be genetic links, it may run in families, and it can happen at any time from puberty. It can be diagnosed from any time. Some girls never start their menstrual cycles, and it's diagnosed in teenage years. So that's something that often medics aren't aware of, perhaps therapists aren't aware of, clinical staff may not be aware of, and so it's always something that I would be reminding people is that there is no too young for menopause. We certainly find in the UK that people get turned away from GPs and doctors because they're not that magic age of 51. But actually, that's just an average.
Thank you. Thank you for providing such a thorough framework as we launch into this conversation today. My observation, both as a woman and as a clinician, and knowing from the research as well, there's so much bias in medical and mental health care with women, and so much of what we experience could be dismissed because of quote unquote hormones, or could be underexplored. These symptoms that women may be experiencing and then report to their primary care doctor, and they're not investigated or feeling like they're not being listened to. This phenomenon is even stronger with queer women, for women of color. These are very real inequities, and I can only imagine how they're contributing to confusion for people who have internal reproductive organs of like, this stuff is happening. Tell me about some of these symptoms, knowing that there's such a wide range.
So yeah, as we were talking about earlier, there's a lot more symptoms than people initially imagine. When menopause is talked about, it's often hot flushes or flashes and insomnia. That's often the first things that people talk about. Yet it's so much greater than that. There are, and to my count, around 40, possibly more symptoms of low estrogen or low progesterone or low testosterone that people would be expecting. So anything from weight gain, a different weight distribution is often reported, joint pain, exhaustion and fatigue, paresthesia, which is tingling, pins and needles, in your extremities. Obviously changes to menstrual cycle, so irregular periods. Often people might experience spotting before their period, which they may have not done before. A shorter menstrual cycle. It's very, very common at different phases of the menopause transition. Perhaps some people experience much stronger, they might experience flooding, much heavier periods than they've had before. Others, it becomes lighter gradually. They tend to be the luckier ones who tend to have not quite such high fluctuations in menopause hormones. So burning mouth, a metallic taste in the mouth is quite common. Changes in taste, things taste a bit different. Changes in body odor, that's a really interesting one because it seems to happen quite suddenly when it happens for people that they think, hang on a second, I don't smell like that, and I'm perhaps smelling a bit more than I normally do. changes in how your breasts feel, some breast tenderness, tinnitus can often happen. I think I mentioned dry eyes before, perhaps. So dry eyes, itchiness, anything that's involving dryness. So when your skin is drier, or your eyes are drier, or your mouth is dry, you often get a lot of these feelings, these symptoms that are different. Dry hair, hair loss, heart palpitations, heartburn, and gastrointestinal issues often happens. Migraines and headaches, which is often in that earlier phase when your estrogen is higher than your progesterone. Reduced libido, different food cravings, issues with sleep can be related to hot flashes, night sweats, and sleep apnea and snoring, because things change in the way that our kind of our throat is when we sleep. The lack of estrogen relaxes everything, so you're more likely to have a sleep apnea and snoring. Joint pains, nausea, balance issues. The list, I could go on for hours, as you could probably tell. And one area that I haven't mentioned, which I am really keen to talk about because people are often quite ashamed of mentioning it, is genitourinary syndrome of menopause, which is the impact of low estrogen, which tends to happen in later menopause, but for some people can be an early symptom as well, which is vaginal dryness, often irritations for the bladder, urethra, all of the skin around all of these organs, around the anus, and can cause fissures. That is when the skin starts to thin. And the thinner skin can mean that there's tiny tears, there's irritation, you're more likely to have UTIs and urinary tract infections, and the bladder can be quite irritated. The urethra can sort of kink sometimes. And so there could be a lot of urinary changes and pain that happens with menopause. And that GSM, the estrogen receptors not getting the estrogen locally within the pelvic area, can lead to embedded UTIs, so real problems getting rid of the UTIs. They don't respond as much to medication as before, and also problems like prolapses. So there can be some really quite debilitating issues from low estrogen if it affects your genital and pelvic region. So that's something that I always think is worth talking about.
Whew.
Oh, itchiness as well. Can create some itchiness. Having said that,
That's a lot of symptoms right there.
Very easily treated with topical estrogen. It's not something that goes away after menopause, but it is something that can be treated and relatively safely as well.
So going back to your earlier statement about premenopause and then perimenopause, at the point that a person is in premenopause, can you really identify that? Or is it only a stage that happens retrospectively where you say, oh, okay, this time period was before these symptoms started, so that was when I was premenopausal?
Yeah, absolutely. You're unlikely to know it. There's a language thing to note here, which is that sometimes people use premenopause when they mean perimenopause. So there are two different stages, but I often hear people say, well, I'm premenopause now. And then they start talking about symptoms like hot flushes and some of those symptoms we've mentioned. And actually that indicates you're in perimenopause. You're not in that premenopause stage.
And again, on the language, so commonly we say, oh, I'm going through menopause, but the point that you made, menopause is a single day. So what do we mean when we say my period has stopped, I haven't had a period in a year and a half, let's say, and I have these symptoms and my skin is different, my hair is different, I have stomach problems and I have mood changes and yada yada. What's actually happening there? Is it postmenopausal?
So yeah, officially it's postmenopause. If you haven't had a menstrual cycle for over 12 months, it's postmenopause. Usually we say I'm menopausal or I'm in menopause or I had menopause. I mean, it's, the terms that medics use aren't necessarily what we use in our everyday conversations when we're talking to our friends or our family. And the menopause transition is this whole phase, which, as I say, can last 12 years plus. So you can at any point there be saying, well, I'm experiencing menopause symptoms. And those symptoms can continue post-menopause transition as well.
That was going to be my question. So if we're looking at the whole transition of potentially more regular periods, absence of these symptoms with any luck at all, and then all of this happening, is there really another side where there's like a resumption to the way things were before? Or is it that the body is just a different body when this change happens?
So it depends on the symptoms. The body is having a big adjustment. It's like a second puberty, the menopause transition. And some things are different and some things are revert to how they were before. So the body needs to get used to the lower levels of hormones. And for some people it can adjust gradually. If the hormones drop relatively gradually, if the body is less physiologically stressed, we can talk a little bit more about that later around kind of the reasons why menopause can be quite difficult now. So if somebody is having a relatively easy menopause transition, their body is adjusting much more easily to the changes in hormones, and they may get fewer symptoms and they may not notice much change except for obviously the cessation of menstrual cycles. Other people, it might be much harder for their body to adjust. The symptoms, perhaps if they have co-occurring conditions, that those symptoms may be harder because estrogen isn't padding them out and making things a little bit easier. I like to think of it a bit like oil or kind of a lubricant for the body. It's there. It's easing things. Everything is drier without it. So some things that may perhaps be manageable with estrogen then become more difficult when after menopause, depending on what other conditions that you have. So some things, so genitourinary syndrome of menopause is an area of the body that does not improve. If that's something that's happening, then that's something that does need to be treated. Otherwise it stays the same or gradually gets worse. So that's an area that is a lifelong condition if it started to happen. Other things, the brain cognition issues that people have, the memory lapses, brain fog, those sorts of areas, which I don't think I actually mentioned with that big long list of symptoms, they tend to improve once the body is adjusted to the different changes. The night sweats and hot flushes tend to improve. Occasionally people do continue to have them later in their life, but most people find that once their body adjusts, and they under less physiological stress as well. And over the time, as the body gets used to the lowered levels, those things improve.
Thank you. Thinking about timing, as you said, certainly we have stereotypes in our minds about this is how long this is what age this happens. For clinicians listening, really at what age should our ears start perking up for a person that has internal reproductive organs to wonder, wait, tell me again about those night sweats and like that you keep forgetting where you are when you're driving. Like, tell me about that.
Mean, I would say any age, just from what I said around the 1 in 100 having a natural menopause, or it's like those people who have POI don't necessarily want to call it menopause often because they don't necessarily want to associate with aging, but it is a similar process that's going on in the body. So I would say if somebody's saying that they're feeling extremely hot at night or they are experiencing any of these symptoms at any age, I would be suggesting that they go and see somebody, a medic, and get their bloods checked or have a conversation with them about those symptoms, because it could be happening at any age. But typically it's in your 40s. That tends to be the time that people start experiencing these things, any time from your late 30s. I think I said the average onset is 47, but I think that tends to be the big symptoms. Often there might be something that's happening before, but then it's only really when you start waking up, soaking the bed sheets in sweat at night, that you think actually something's really wrong. Because a lot of people find that if they do choose to take menopause hormone replacement therapy, that they suddenly realise that some of the things that they've been coping with for ages don't cause them harm anymore. My bad back that had been chronic for decades, I've never had a back problem since I've started taking HRT, which indicates to me that there was something going on with my hormones that was actually impacting my back.
Thank you. I want to circle back to talk more about hormone replacement therapy, HRT, as Helen just mentioned. When thinking about one's likelihood of, we'll say, early menopause, which what is that? Because that just seems really relative. Is there a higher likelihood among people who have family members who tend to go into earlier or later? Like, how much of this is genetic?
Absolutely. So we don't know. So there are definite genetic links. If your mother, if your sisters, if your aunties, if your grandparents our grandmothers had an earlier menopause, then it's more likely that it might happen to you. It may not be. So there is definitely some genetic links that affect some people, but also perhaps some of those might also be genetic predispositions to autoimmune diseases, perhaps, or something else that might trigger. There's also potential links to trauma. So sometimes people find, and actually that often happens, that my clients with POI have had a significant trauma at some point, and then this has happened afterwards. And whether that's linked to autoimmune or something else, there's not enough research done in these areas to really understand. Some people are able to find out themselves. There's different syndromes. There's chromosomal syndromes like Turner syndrome that can impact menopause. Your question earlier about early menopause. So that's a menopause between 40 and 45. That's early menopause. So anything before 40 is premature ovarian insufficiency, sometimes called premature ovarian failure, but that's increasingly not used anymore because of the negative connotations. And also that if you do have an earlier cessation of ovarian function with POI, it doesn't necessarily mean that it's stopped. So 5 to 10% of people with POI can go on to have ovulation, have a menstrual cycle, and they can go on to conceive. There is a chance of conceiving afterwards if fertility is something that your clients are particularly worried about. It is possible.
Talk to me more about primary ovarian insufficiency. So, as you said, about 1 in 100. And I appreciate what you said earlier as well about, well, really any age, if you're that one that's experiencing this. There's so much here, so many hormones that are coming into play. Want to talk with you about kind of testing and recognition and providers, and then also treatments. But let's dive in a little bit more about primary ovarian insufficiency so that we as clinicians know more and might be able to help recognize it.
Sure, of course. So, as I said, it's much more prevalent than most of us imagine. It's often one of those things that you only really find out about if it's happening to you or someone that you know or care about. And it's very little research has been done. The experience of somebody with primary ovarian insufficiency is so different as well, depending on what life stage they're at, what age they're at, how it's impacting them. Because somebody who finds out that their ovaries perhaps haven't developed fully or aren't functioning as they would for your average, say, 18-year-old, will be having a very different experience than somebody who finds out when they're, say, 38 and trying to conceive. Or somebody who finds out perhaps when they've completed their family, that could, because of the impacts on fertility that comes with primary ovarian insufficiency. So many of the symptoms are, well, as varied as they are for the natural average age menopause transition. So some people might maybe only find out when they've stopped the contraceptive pill that their periods don't come back normally as they're used to. They may find out because their periods never start, or kind of start and splutter to a stop quite quickly. And so there's this huge range of experiences, and it's very difficult to speak for everybody who has the POI diagnosis, especially, as I mentioned before, that there's people have it because of cancer treatment. And obviously there's various choices that you can make. You may try to get some eggs through a IVF style process of gathering eggs beforehand. If you know that that's happening, that may not be an option. There's also a chemical menopause, which is what someone with PMDD, premenstrual dysmorphic disorder, may choose to do as a treatment, which is to take various hormones to stop a menstrual cycle and then experience menopause because of that. And that might be a choice that's taken with your doctor. Obviously, I'd just like to say I'm not a medic. I am a cancer psychotherapist, but I don't have a medical qualification. So this is gathered from my own research and experience and learnings, but I'm not a qualified doctor.
Primary ovarian insufficiency, how is that diagnosed?
So again, it can be quite challenging. It's typically diagnosed in the UK, and I think in the US will be similar, by two tests of the follicle stimulating hormone 6 weeks apart. And if both results that are high, the follicle stimulating hormone is high, then that indicates that the body is really trying to push out some eggs. It's really trying to get the last of the eggs by stimulating those follicles. And that indicates, if it's 6 weeks apart, then it's likely not linked to a menstrual cycle. And that is the best or the safest way to diagnose. It can also be diagnosed through antral follicle count, so how many follicles you have left on a transvaginal scan. And there can be other hormone indications that ovarian reserve is low. For example, the AMH, the anti-Müllerian hormone. Sometimes if somebody's going for IVF treatment and fertility treatment, this is one of the blood tests that will be done, is a test for the anti-Müllerian hormone. And if that is low, then that will indicate that ovarian reserve is low. So that's, and if that's in combination with antral follicle count, there may be a POI diagnosis. Doesn't necessarily mean that IVF isn't possible or that IVF with your own eggs isn't possible, but there's often, it depends on the level of AMH, but often if it's low, then somebody may be advised to try donor eggs for an IVF cycle, which can be a way of completing and creating a family, which is, greater success rates than IVF with a low AMH and low follicle count.
As we're talking about this, of course, we're approaching this from a clinical perspective and describing symptoms and prevalence. The lived experience for people assigned female at birth, this thing that happens when we're in our teens and changes us, separates us from our peers, and then affects us for most people every month for many years, that also comes with so many risks, of different cancers and things like endometriosis. Goodness knows there's just a laundry list of things that can go wrong with internal reproductive organs. These symptoms that you've listed are really disruptive. I'm thinking of what it means for someone to be experiencing brain fog, what it means for somebody to experience weight changes when their clothes don't fit anymore, when they're having trouble getting out of bed because they have so much fatigue, or they're changing the sheets every single day because their sheets are soaking wet from sweating. The mood changes. That's such a big stereotype in our culture to kind of make fun of, leave her alone, like she's on her cycle or whatever it is. But it's really disruptive. Knowing that there's so many presentations, as you just said, and that we're not medical doctors. When it comes to you as a person who specializes in working with people who are in perimenopause, postmenopause, in this transition, how do you best support them? Because it's a huge thing to see your body change so much, to experience that.
Absolutely. And it's different for every person. A lot of what I do is normalizing. So I normalize a lot because we don't talk about this enough, because women or those with internal reproductive organs are not necessarily being honest, perhaps, with their friends about what's happening for them. Some of these symptoms can feel quite embarrassing. People can take a while to adjust to what's happening to them. There can be associated impact on self-esteem, on feelings about aging, on feelings about being a woman, and what that means if you're perhaps not able to conceive anymore, whether that means that you are quite the woman that you thought you were before, or the person you thought you were, and how much our cycles, as you said, we cope with them for decades. They're such a part of our life. They're such a part of what we expect, what we know. Even the fact that when we're in puberty, you don't really know when your menstrual cycle is going to turn up, or for a lot of girls don't really know. They don't really know how heavy it's going to be. They don't really know how to cope with it. You might carry around a bag of products, of things that you could cope with if you need them. And it's the same again, the other side in your second puberty, and nobody really expects it. You think, well, I've got this. I've been coping with this, if you don't have particularly difficult periods, for however long. But if that progesterone is low, then you're more likely to experience flooding, you're more likely to experience just really different periods than you've had before. And women are caught out, and that can be really difficult. So a lot of it is hearing, listening, trying to understand what it's like, using obviously my therapeutic skills of empathy and really hearing what that experience is like for that person. We can experience menopause, but menopause is different from one person's menopause is very different to another person's menopause, and really understanding how it's impacting their daily life, their family, their work, their responsibilities, what they're able to cope with, what regulating strategies we can we can bring in. I often work with clients on a toolbox, creating a toolbox of different things they can do to support them at perhaps different times of the month. I might be looking at them to looking at the regularity of their symptoms and really understanding whether it's that luteal phase, that phase after ovulation and before a period starts, that often people have struggled with. And perhaps they need to plan their calendar differently. Perhaps they need to work differently. Perhaps they need to reduce social engagements in their luteal phase if they really struggle. Perhaps they have PMDD, because that happens more as people approach menopause. Often PMDD symptoms worsen. And there's also neurodivergence, so the impact that hormones have on serotonin, on dopamine, can make a real difference. And so often people don't realise that perhaps that they're neurodivergent, and then their symptoms really catch up with them in menopause. The coping strategies that they've used don't work. I often relate it to the wheels coming off. You've got your ways of coping, your ways of working, your ways of being, and then as those hormones fluctuate, that really impacts some of those feel-good hormones, and it really impacts emotional regulation. It impacts cognitive. There's cognitive impairment, there's executive functioning issues that get heightened as menopause drops. So it's really, in terms of how I work with clients, it's really individualised. It really depends on what they need from me. They might need support, encouragement for psychoeducation. Where do they find out about their what's happening to them? Really understanding what's happening in their body can be really empowering, can be really powerful to understand. CBT, cognitive behavioural therapy, is recommended by the International Menopause Society, British Menopause Society, I suspect the North American Menopause Society as well, because it's an evidence-based, proven method to support women, particularly with anxiety, with hot flushes, with insomnia, with low mood. A lot of the time, to use hot flushes as an example, with CBT, we'd be really looking at what does that person feel like when they're having a hot flush, when they're sitting in a meeting and they suddenly realise that they're sweating and their face is red. Often there's all of these negative messages that they tell themselves. Oh my God, everyone thinks I'm red and sweaty. Everyone thinks I don't know what I'm doing. I've forgotten what I was going to say. I can't cope with this. What's happening to me? They flap. They take all of their layers off. They really struggle. And cognitive behavioural therapy can help challenge some of these assumptions and beliefs and look at actually how long does that hot flush last? And perhaps if you can change the message that you're giving yourself, rather than catastrophizing, to be starting to say, oh, this is a hot flush. It'll last 10 seconds to a couple of minutes. I just need to breathe. And then that can really impact the impact of the hot flush. It can be much easier to cope with, and those just the messages that you can get, the rewiring of how you respond that can be achieved through CBT can be really helpful. That helps, and insomnia. Really looking at sleep hygiene, looking at what are you doing, what's your sleep routine like. Are you hot at night? Could you have layers? Could you have windows open? What happens if you wake up at 4 a.m., which is such a classic perimenopausal thing, is that our bodies, firstly, our temperature, the zone of temperature regulation, it's almost like our thermostats go a bit wonky, and our body responds. The zone is much narrower, so while our body temperature is not really changing that much, our body responds to a change in temperature as though it's much greater than it is, which is why we suddenly, flap and get red and sweat and have all of these reactions, is because our body believes that it's under threat from being too hot, and actually it's not necessarily, but it's how the body responds to it. And so if we can start to understand what's going on and why we're waking up at night, perhaps we can use cooler sheets, layers, those sorts of things that can help. That, there is no magic wand for hot flushes other than HRT and estrogen therapy and night sweats, but all of these things can help.
That
CBT can.
That was going to be my next question. I'm like, here are all of these really disruptive, unpleasant things that may be experienced, if a person's having a difficult menopause transition. What are some of the treatments out there? And second to that question, how effective are they? In wanting to be realistic with ourselves to understand, like, what can a client expect? Because goodness knows, particularly in United States culture, we really like being able to take the little pill out of a bottle and make the bad thing go away. Like, so how feasible is that? I would love to hear kind of what are treatments and how well do they work?
So the gold standard, the obvious treatment is menopause hormone replacement therapy, so HRT. So that is typically a combination of progesterone or progestin, which is a synthetic version, and estrogen or estradiol in different forms. And there's so many different forms of HRT that your clinician, your GP, your gynecologist, or whoever you are seeing to be treated for menopause can help decide which is right for you. There are people who are advised not to take HRT, for example, those with strong history of breast cancer in their family. They may not choose to take HRT. And for those people, there's evidence from a medication point of view that antidepressants, SSRIs, can be really helpful. They can reduce hot flushes, they can improve mood. They won't be able to cope with, say, GSM, so vaginal atrophy or genitourinary syndrome of menopause. That's not going to be impacted, but it does take away, if it works and the levels are right and it's titrated properly, they should really cope with a lot of those symptoms that without necessarily replacing with hormones. So there are medical options without taking HRT. With GSM that I mentioned, the vaginal creams or pessaries, the little pills that can be inserted, they're really effective, and most clinicians say that they're safe even if there is breast cancer risk. So that's something that if it's happened to you, if you're experiencing vaginal dryness, perhaps painful sex, perhaps the cervix feels lower than normal, because as particularly vaginally, everything kind of shrinks a little bit, and then you're more likely to have pain or a bit of bleeding after sex. So that's something that could just be aware of. Any sort of intercourse or penetration can cause pain and little spots of blood. So that's, if you're having that, obviously go to your medical provider and find out what's going on. But if that is a diagnosis, it can be treated. There's a wonderful book by Jane Lewis called Me and My Menopausal Vagina. It's published in the UK. Jane Lewis has done an incredible amount of work on destigmatizing GSM and explaining all of the things that happened to her when she was experiencing it. And she's also got a Facebook group she had one. I don't think she runs it anymore, but that's a place to get lots of information and support about how to treat it. So there is a wonderful book as well called Natural Menopause edited by Anne Henderson, and that has a page on all of the different treatments and talks about it. So there is a lot of holistic treatments that people can try. Obviously, lifestyle measures is really important. And it's the first thing that people should be looking at, which is, are they sleeping well? Are they aiming to practice good sleep hygiene in order to sleep more? Because menopause is likely to disrupt sleep. What can you be doing to improve your sleep and make sure that you're getting better quality sleep? What can you be doing to improve your stress levels? Because it's known that physiological stress, so the stress that our body is under, will really impact menopause symptoms. So if somebody is physiologically stressed, if their body is under a lot of stress, they're more likely to experience worse symptoms than if they are leading a calmer life and their body is healthy and their body isn't already struggling. So what diets, there's often vitamin D levels are low, particularly in the Western world. And so that is something that can be looked at, is whether there's a lot of people find supplements like magnesium or black cohosh or choline. It would obviously be sensible to talk to a registered nutritionist to find out what's relevant to you. But some people report that they really do impact some of the menopause symptoms. So looking at your diet, looking at lifestyle, weight-bearing exercise is crucial as we age to prevent the deterioration of bone health that happens with lowered estrogen. So one of the real risks of an earlier menopause is osteoporosis that happens with women much more, and that's to do with estrogen and the lowered estrogen. So the more that we can protect our bone health as we are aging, so that's adequate calcium intake, adequate vitamin D, probably supplementing, most people do, within the Northern Hemisphere at least, they typically need to supplement, and weight-bearing exercise, strength training, weights, all of, kind of shifting more from cardio exercise towards more strength and flexibility, that can be really important and make a difference. I'm not saying it's going to solve all of those symptoms, but it may reduce some of them and generally help you feel better. And then there is, like I say, CBT that can help. Therapy, talking therapy, being able to talk about what's happening, what's going on for you, how you're experiencing how to make changes in your life. Sometimes people need to make changes, perhaps their work environment. There is, I can't recall the stat exactly, but there's amazing statistics and sad and distressing statistics on how many women leave the workplace during menopause and make changes. And sometimes I think that's an active choice. They may be choosing to live their life slightly differently. There is a change sometimes in attitude that women can report with after menopause, where they just don't want to necessarily be pleasing others quite so much. They want to be focusing on their needs more than they perhaps have been. If we think about the stage of life of the average age of menopause at 51, often people can still be caring for children. They might have teenagers, they might have even younger children at home. They might have children who've flown the nest and have more opportunity to make some changes to their life that they haven't done before. They may have been in caring roles for years, or they may have aging parents who need looking after differently. They may be realising that they've got another decade or so, 2 decades perhaps of working, and perhaps they don't want to be doing that job anymore, and they could be doing something that aligns more with their beliefs or aligns more with the lifestyle factors, things that they want to change in order to have a more holistic life. There's lots of reasons why women make those sorts of changes.
Knowing that HRT is one of those terms that's really thrown around, so hormone replacement therapy, I'd like to talk about what that therapy looks like and how somebody finds out that they are potentially either a good or bad candidate for it. And, other than cessation of period, how in the world does a bioidentical hormone exist? Like, what does that look like from a practical standpoint?
Sure. So the majority of the bioidentical estrogens now are made from soya, and so that's where they come from. In the past, there was Premarin, which was often used, and that's now not used so much because of the risks on heart health and breast tissue. That also has ethical considerations for lots of people because it was extracted from pregnant mare urine, and that was found to be, and it was an early HRT, an early form of estrogen that was used, but it's now regularly not being used, and it's in preference. People tend to prescribe and ask for body identical or bioidentical, they mean the same thing, depending on where you are in the world, hormones, which are much better for the system. Similarly, there can be chemical progesterones or progestins, or there can be more bio or body identical progesterones. So that's often in a pill form, something like, it's often marketed as utrogestan. And that can be something that is kinder to the body to take because it's more aligned with our natural hormones. So there's, HRT is evolving. It comes in patches, pills, sprays, gels. It can encompass creams as well, and it's anything. Either there can be a variety of different forms which have different levels or combinations of what mimics estrogen or is a type of estrogen, what is a type of progesterone or mimics progesterone, and testosterone as well, which is increasingly being used and prescribed, although it's not yet part of guidelines, menopause guidelines in most of the world, but I believe in Australia it's part of their guidelines, and certainly in the UK it's not part of the NHS, the NICE guidelines, but it is. There are various situations when it can be prescribed by GPs on the National Health Service.
Given that there isn't some hard and fast test, like thinking of pregnancy, for example, there is a test that is generally pretty accurate in recognizing this is in your body at this level, that means that you're probably pregnant. Given that there isn't a test for that, how does one know when it might be the right time for something like HRT, or is it just these symptoms appear to be perimenopausal and let's give this a try?
Yeah, it's that often. That's often what, in conversation with the doctor, might happen. Typically, certainly in the UK, if you are 45 or above, the GPs tend to go on symptoms because that is quite an average age for people to be in perimenopause. If you're below 45, typically it's those blood tests. It's just checking, and a doctor may wish to do a full blood panel and see if there's anything else going on. It's really sensible to be checking thyroid, to be checking other conditions that might be happening that can look the same as menopause. One of the challenges and why it's often not diagnosed is because it could be so many other things. It could be that you are having anxiety or depression. It could be that you are having perhaps you've developed celiac disease and that's impacting and creating bloating or some other symptoms. And so it's always worth being, checking, and a good doctor will be checking that there are to ensure that there's not something else going on that's causing these symptoms. But if there isn't, and if it all appears to align, then sometimes people choose to try HRT and see what happens. They do recommend that and it often won't be prescribed if you're more than 10 years past your last period. So there is a time when to start HRT can be more dangerous. And so they don't like people to start much later. So it's something that if it's happening, then perhaps it's something to try. What I would say, though, is that it can sometimes be talked about in media. We find celebrities often talk about HRT, particularly in the UK, and they can make it sound like you just slap on a patch and you feel amazing. It's like, just take this and it's going to change your life. It's not really like that for a lot of people. It can improve, but because it's symptom-based, it's really hard for somebody to know what normal feels like for them. What does normal feel like for a really tired, stressed, busy person who is perhaps, working 2 jobs or, has a job and has children at home and perhaps has a whole host of responsibilities that are making them tired and stressed? How do you know whether your insomnia and your poor sleep is to do with the stress that you're under? How do you know whether your fluctuating periods might be to do with stress that you're under? Perhaps you're not eating very well because you can't. Perhaps, money is tight and so you're not able to do some of those lifestyle measures, which a lot of them are, to hit hit all of them and be perfect. There's a lot of privilege that's there that you need in order to be able to do that. And most of us don't have all of those privileges. So to try and work out what's happening can be really difficult. And sometimes people only find that they know know that it is menopause because they have taken HRT and it improves, or perhaps their periods do stop and their symptoms gradually improve. What I would say, though, is that I'm conscious that I'm perhaps making this sound like it's just awful for everybody. And it's not necessarily. 25% of women and those with internal reproductive organs do have a relatively seamless menopause. 50% have a menopause that they might need HRT, they might need some support, they might notice some changes that are quite debilitating or difficult, but they're probably okay. And then there's the 25% who really have a difficult time of it. So what we're doing really is highlighting that and focusing on that, because traditionally those people have not been heard, they've not been understood, they have been turned away by doctors, they have been told to get on with it by people around them, and that may have happened throughout their menstrual cycle life and when they've had problems. Because if you do have more PMS, PMT before your period, if you do have more irregular periods, it's slightly more likely that you're going to be having a more difficult menopause transition as well, which does seem unfair, but it is unfortunately how it is.
Luck of the draw.
Yeah, I mean, some people just have, and generally there is not enough research, despite the fact that women and assigned female at birth have been having menstrual cycles for the whole of the existence of the humankind, and mammals have it everywhere. There is not enough research as to what's really going on and what the wide variety is. It's infuriating for somebody who doesn't have a regular 28-day cycle to read and learn about periods and learn about menopause, because a lot of your experiences just don't fit in. It's not the same. And we talked earlier about what's normal, but how is a girl who's flooding through her sanitary protection, how do they really know if they're young what's normal, and that perhaps what their friend thinks is normal is perhaps a particularly light period? It's really difficult for people to know. And how do you even measure? You're expected to know and have an assessment of how many teaspoons of blood you shed in a menstrual cycle, but it's really hard to know because it can feel like, jugs of the stuff, depending on your experience. And so this kind of idea of of normalizing and really understanding what's debilitating, what's difficult, what can you cope with, what's hard for you, and therefore what can be done about it. And I do a lot of signposting to GPs and signposting and saying, that sounds like, perhaps your estrogen and progesterone aren't quite right. Perhaps you are, experiencing something that could be helped. So that I do a lot of signposting, a lot of normalizing, a lot of really understanding what's the practical impact of what's happening for these people who come to see me, and what's the impact on work, what can they do. We do a lot of tips and tricks. I mentioned a toolbox earlier, but have a toolbox of how can you, if you're having a particularly tough week with your hormones, what helps you? What's is it going out and trying to squeeze in a walk at lunchtime for the fresh air, the vitamin D, the regulatory nature of a bit of gentle exercise? That can really help a lot of our symptoms just in the moment and help us get through the day if we're working.
Given how broad of a presentation there is, as you said, a quarter of people may not have really significant, unpleasant menopause transition symptoms, and they run the gamut. I would imagine that this may potentially take time to be recognized by doctors. Like, knowing that, say, autoimmune disorders, most people who have autoimmune disorders have been going to the doctor for years saying something is wrong, and that it often takes years for the right test to be run or the right clinical diagnosis to finally be assigned and for treatment to begin. I would imagine for primary ovarian insufficiency, that's one of those that probably goes under recognized. Is that true?
Yeah, absolutely. Yes. And it's only often once it's been diagnosed that you can look back and think, oh, wow, that's what was happening. I myself, I started experiencing symptoms, I think, in my 20s when I came off the contraceptive pill. And if I look back, every time I had a break from the contraceptive pill, I had symptoms, but I didn't know that that's what it was. I didn't realize that I had GSM and it was misdiagnosed as thrush, but the thrush creams didn't work. So I just thought it was just me and got on with, thought maybe I'm not doing it right, or, went back and forth, and no one ever suggested that I might have low estrogen, but I did. It was one of my first symptoms. I was having night sweats and hot flushes in meetings. I was in my late 20s, early 30s. And I remember the first one distinctly because it felt different from anything I'd had before. It was like a voomph from my chest up to my face. And I remember thinking, that's weird. I'm not stressed. Like, I wasn't really worried. There was nothing going on in the meeting. And I felt so discombobulated. And I took my jacket off and I thought, why, what's going on? But then I thought, I was in quite a stressful job. I was working long hours. I was physiologically stressed. I was commuting. I was working in London. I was, probably not, I was exercising, but I probably wasn't resting as much as I should be. I probably wasn't looking after my nutritional intake quite as much as I could have been. I was probably having a little bit too much alcohol, perhaps, which would have increased the chances of hot flushes. I worked in an industry that had a lot of entertainment as part of the job in the evenings, but I didn't know what it was, and I assumed it was anxiety. And as these things continued, I then actually left my job because I felt emotionally unstable. I didn't feel like myself. I felt like I was going mad, and I left my job, and it was almost 10 years until I was diagnosed. But I'd been back and forth to doctors for different reasons, which all in hindsight were linked to menopause.
Thank you. Thank you for your disclosure and for answering that so honestly. I think that highlights how disruptive and disturbing this is. And also thinking about how, at least in the United States, some states offer short-term or long-term disability benefits for time off of work. And if they're there at all, they're often not easy to obtain. You have to have a doctor who's willing to write that. And I would imagine, I don't know if this is true, and I don't know if you do, given that you're in the UK, just the diagnosis of menopause or postmenopausal probably doesn't qualify for disability. So someone could have these really detrimental symptoms that are impacting their quality of life and their functioning, profoundly affecting their work life, but they may not have many resources to do anything about it. Their jobs are at risk. They're tired. They don't feel good. As you said, you feel like you're going crazy. And there's not necessarily much to do to help give you some respite.
Absolutely. And there is a really distressing increase in suicide ideation as well for women in their 40s and 50s. And a lot of it is potentially linked to this menopause transition that's not being understood, and the stress, the madness that people feel. I regularly hear people say, I think I'm going mad. It feels like I'm going mad, because the mood changes, the self-esteem changes, the irritability, I mentioned what a hot flush felt like for me. Anger and irritability also felt similar. So sometimes out of nowhere, it was like a woomph of white hot rage. And lots of people report this, and it's not normal for them. And perhaps that happens to them at work, somewhere where they normally might have been quite controlled with their emotions. And then they suddenly feel like they're out of control, perhaps with tears, perhaps with anger, perhaps with irritability, perhaps with, responding a bit unmasked in the way that they are in a situation. And these things can really impact sense of self and who you feel that you are. And yeah, these things often happen. And as you were saying about menopause, there are increasingly, companies are writing menopause policies, menopause at work policies, which is great. I'm not sure that much action is actually taken, and I suspect quite a lot is lip service. But one of the really distressing things for people with POI as well is that they're often not included in that. So they might be saying, well, this is happening to me, but they don't quite kind of come under the disability that they perhaps should. And if their GP could write a good enough letter, their HR department, their people department might listen. But for a lot of people, they're under the radar. And of course, even though it is being talked about more, there is this stigma on women, and stigma that women feel often around aging. It's not just the self-esteem that's linked to the changes in fertility, but also what impact that has at work, particularly if your body is changing shape, particularly if your work clothes don't fit like they used to, particularly if you are experiencing those debilitating brain fog moments, then keeping up your self-confidence in the workplace is difficult. The amount of women who leave professional jobs or just other jobs during their menopause transition means that there's not very many women to look up to either who are coping and managing. So it's really difficult.
It sounds like your observation in doing this work is that one of the first pieces is recognition and saying, I'm wondering if this might be going on. And when I say to clients, I point to myself and I say, not a doctor. I am not an MD. However, I'm wondering if this might be something you want to talk about with your doctor. There's the recognition of the symptoms. There's a referral. You mentioned just acknowledgement of how difficult this is. I'm imagining too how beyond individual therapy, how effective group therapy could be.
Absolutely. Yeah, it can be great. I think it could be a really positive experience to understand that other women or those with internal reproductive organs are experiencing the same thing together, and finding strategies, finding solace in group experience. I think it could be really positive.
And
Yeah.
you had mentioned about CBT, and I'm so grateful too for you covering some more information about the treatments that are available. You had briefly touched on it earlier, but stepping outside of the Western allopathic world, you talked about supplements, but also Eastern. I heard you mention that word in there. Can you speak a little bit about some of the complementary medicine treatments that might be done to help ease menopause transition symptoms?
I can, yes. I mean, there is different responses to menopause. One of the things that's interesting culturally is that not every culture talks about menopause, and in some cultures it can be seen as a really positive transition. One of the really difficult things around supplements is that there's no proven evidence, and so the International Menopause Society and other menopause societies don't recommend them because there aren't necessarily evidence-based trials to show safe dosages, to show the impact that some of the supplements may have with other medication that you might be taking or other conditions that you might have. So I can't ethically recommend anything, but people do find, I think I mentioned earlier, that things like magnesium can help. There are some wonderful resources out there written by by people who have experience in this field that can recommend. And some people find that practices like Reiki can be really helpful. Anything that you find regulates and supports your your body to be able to rest and recover and reduce stress and can be great. And like I say, vitamins, making sure that your vitamins, you might want to see a registered nutritionist to really understand what works for you and what holistic practices. Often, I mentioned briefly strength training, I think, before, but things like yoga that can be really beneficial. So our vagus nerve, the nerve that runs down the back of our body that is so important, and obviously polyvagal theory looks a lot about how to balance and regulate that. So practices like yoga can be so helpful for menopausal people, because not only do we tend to get tighter, our muscles get tighter, our flexibility gets worse. It can really help with the stretching, but also a lot of the inversions, they can help our vagus nerve. A lot of the kind of weight bearing exercise can be positive. Doing a plank is great for your bone strength and your muscular strength and your core strength, and supporting all of these different areas of your body. So I'm not sure that answers your question.
It does answer my question. This hour has been so helpful and clarifying for me. I can only imagine how it's been for our listeners. For people who are listening and want to learn more about you and your work, what's the best way to do that?
Sure. So my website is themenopausentherapist.com. I'm planning actually to put some more lists of resources for different presentations up on my website soon. I haven't quite got the page up yet, but I will be having more information. There are some incredible books out there that we may be able to link to. One that I've been reading recently is The Hormone Repair Manual by Lara Brydon. She's a Canadian-Australian who has her books really good at explaining what's going on and different areas. There's lots of information there's a book called The Complete Guide to POI and Early Menopause. So we talked a lot about POI today. So if people are interested in that, I'd also like to recommend the Daisy Network, which is a UK-based charity. And I believe it's the only one globally that looks and supports POI and premature ovarian insufficiency. And it's a great place to find support and information about it. It was certainly where I started when I was diagnosed. I mentioned, I think, the natural menopause. All of the work for CBT, I trained with Myra Hunter and Melanie Smith. They've done a lot of research. Both of them have done a lot of research on CBT. There's too many papers that they've done for me to list them all, but they've done a lot of research, and their CBT course with the British Menopause Society is excellent. So it's reasonably accessible, reasonably well priced. They're really passionate about getting the CBT message out to clinicians, to therapists, to MDs, GPs.
Fantastic. Again, for our listeners, this is Helen Bennett joining us from the UK, and her specialization on the menopause transition and mental health impact. Helen, this has been eye-opening. Again, thank you. You've covered so much helpful information, and I'm just so grateful.
Thanks so much, Beth. I always love talking about menopause. I'm really passionate about making sure people know about it and are able to recognise what's happening for them and able to find information and find ways to help them. One of the messages that's always really strong for people is you are not alone. Nobody is by themselves dealing with all of these issues. So yes, I'm glad I've been able to talk to you. It's been lovely to talk to you about it.
Thank you for your work.
Thank you.
You've just finished listening to another exclusive Continuing Ed podcast by Clearly Clinical. If you like what you just heard and you need Continuing Ed credits, please visit us at clearlyclinical.com to check out our one-year membership, where you'll have access to our growing library of Continuing Ed podcast courses. Clearly Clinical, where our goal is to help you learn, grow, and shine.